It doesn't end the pain, it just moves it to someone else. Suicide, a bad choice. Tonight, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. And with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, American Academy of Family Physicians Foundation, and South Dakota Academy of Family Physicians. Avera Heart Hospital, Dakota Allergy and Asthma, CoBank, Fishback Financial Corporation, Vance Thompson Vision, Brown Clinic.
Good evening and welcome to On Call with the Prairie Doc. We hope that tonight's information will help stem the rise of suicide in our state. It is important for all of us to understand and have compassion for those in danger. First, let's take a look at this week's Prairie Doc quiz question. Pick the best answer. According to the CDC, in the year 2016 and in the U.S., there were 1, twice as many homicides as suicides. 2, the same number of homicides as suicide. 3, twice as many suicides as homicides. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your questions about suicide as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send an email to the address on the screen. Joining us tonight is good friend of our program, Dr. Matt Stanley of Avera Medical Group, University Psychiatry Associates, Sioux Falls. Thank you, Matt, for joining us.
Thanks, Rick. Always a pleasure to be here.
So, we know that there's a rise in suicide that's happening right now. I mean, it's becoming worse, not better. Even though we think we're better in many ways in medicine and in psychiatry as well. Is there something happening in our society that might be bringing this on? I mean, do people have a good answer to that question?
Well, I don't know if there's a single answer, and I don't know that I can answer that for you, but I would agree with you. So one of the most disturbing trends in medicine, where we feel like we're always progressing, right, is in this last decade, we've actually seen suicide rates increase. And it's across all demographics. So it's all age ranges. It really isn't about a particular race or religion. It's just generally increasing. And so I have some factors that I think are at play here that we maybe haven't fully appreciated and understood. And I won't pretend that everything we do in psychiatry or behavioral health is at its optimum. We clearly have work to do, and we will continue to get better. Research continues to occur. But I do think some of the trends in society or some of the things that we see happening around us have an impact on this rising rate. And you and I were talking before the program just about the pace of acceleration in technology, and with that, the pace that our lives are changing. And you've probably seen those informatics or things that say, the learning or knowledge is increasing, a logarithmic rate.
Right.
It's doubling every so many years, and it continues to speed up. So I think one of the situations we might actually find ourselves in now, and one of the reasons I think we don't have all the answers is I think our society as a whole and our lives have changed so much over the last few decades. We're not even fully aware of the impact it is having on outcomes like quality of life and indicators like suicide rate or depression or hopelessness scales. I think some of these things are escalating right along with our changes in society.
I mean, we may know more, but we're not happier. You know what I mean?
Yeah.
Or we may have access with our digital little things to all these friends, but we don't have any friends.
Yeah, absolutely.
We're
Or the
isolated.
Right, the friends we have, we couldn't even identify them if we met them on the street. Yes.
Is that part of it? But you know, it's also increasing in the elderly who may not be doing all of this all the time. I mean, suicide's happening everywhere.
Right. So, but you look at, so what are some of the downstream effects of increased like digital awareness or being on those things? We do see some indications of dissolution of family. So for those elderly folks, what you don't see anymore are families living right next to them.
Right. The nuclear family is
Right.
now getting very old.
Right, and in fact, it's almost rare anymore. If I live in Sioux Falls, for instance. None of my kids will probably settle in Sioux Falls, where it used to be like where I grew up.
Everybody was there.
Yeah, my parents were there. My grandparents lived there or the next town over, and you had family all around you. So I don't know that those are entirely the reasons, but I think those are part of the reason.
Part of the safety that I've felt as I'm in this cancer fight that I'm struggling with is the family of the church that surrounds me, and the support and the love of the people that go to my church or that are churched with me, and people are less churched now. I mean, I'm not.
Right.
Maybe it's the fault of the church, or maybe it's just.
Yeah, without even getting into that, I agree with you though, because lay the blame where you will.
Yeah.
There's this less structured support group in a spiritual way.
Yeah.
And if you look at protective factors for suicide, it is things like support of a family, support of a church, spiritual belief. It can be other things too.
Yes.
But one of the strongest risk factor or protective factors that we look at is, is suicide an act you would even contemplate, or do you think it's anathema to your beliefs spiritually or otherwise?
Right.
So there is, I think that's another societal factor that is changing.
That might have influenced us poorly.
Right. Data would back that up. We are less spiritually inclined, or we don't belong maybe as much to the church in the traditional sense.
Yeah, right. Well, I also, this is a time where at least 45,000, maybe 70,000, if you think about it, associated with narcotic overdose deaths in the United States in 2017. If you include other drugs or just alone, but it's a gargantuan number. Why are so many people addicted now? I mean, and that's one of the things. Avera's making a big push, and you're the leading charge of that, to try to bring help to people with addiction.
Well, one of the things I think we should make clear is my perspective on both suicide, which I would tie in with mental illness in the form, one of the major risk factors is a mood disorder, so a depression, possibly a bipolar, and addiction the same way. I view these as medical disorders. They are chemical changes in the brain that change for a variety of factors, can be treated effectively.
It's not the fault of the person.
Right, we have to quit looking at this with a character logic kind of judgment. These are
illnesses.
These are illnesses, and the sooner we embrace that, and more than that, they're chronic illnesses. So they're not even, for many people, episodic. I had an episode of depression. That sounds like it was the flu. You're going to get over it and you're going to go on. For many people, these are chronic illnesses. They'll deal with it their entire life. Addictions certainly fall in that category. And so when we treat addictions, we really need to look at that. Abstinence is a wonderful course, but if you look at anyone who's recovering from a substance use, they also have periods of relapse. Very few recovery stories are just an elegant stream of
got better.
Yeah,
no problem.
This is the day I quit. Never had a problem from that day on. There's usually, there's periods or episodes of relapse. And here's why I think the opioid crisis is different. Because when you relapse with opioids, you're probably not going to go get a prescription to meet that need. You're going to buy it on the street. And what's happened with opioids is, and that incredible rise in opioid related deaths and poisoning, is because the synthetic opioids, the fentanyls and carfentanyls that are anywhere from 100 to 10,000 times more powerful than the prescriptions, they can easily be mixed in what you buy on the street. So essentially, when you go out and buy something off the street, you're playing Russian roulette because you don't know what you're getting. And if it's mixed with one of those, it is a death sentence. You will die. Yeah. And so I think, so if you look at those 72,000 overdoses for 2017, 30,000 of those are related to fentanyl and the synthetic opioids. So about half, or getting close to half. Well, that's something that we weren't even really concerned about a decade ago. It really wasn't on our radar.
That stigma of mental illness is an interesting thing because my sense is, and I'm going to say this, I think everybody has a mental illness periodically in their life. We all go into a down sometimes. Mine happened in college, probably sophomore year in college. I think I was really on the floor. I mean, I didn't lose track of reality, but I was one sad fella. I think we all can have these episodes of mental illness if we all thought that it was not just those sick people over here.
Yeah, well, and that's a great point, and I think it's why it's so I think distressing that we do kind of stigmatize it, because you're absolutely right. If you look statistically, in any given year, about 1 in 4 of us as Americans will meet the diagnosis for a mental disorder. And so lifetime risk is remarkably high. So if you look at all the medical diseases we treat, this is one of the most common. And yet we treat it like it's something entirely different and shouldn't necessarily go seek treatment for it. It should be the opposite. We should embrace this and say, this is a normal illness. You're going to need help to get over it. As soon as you show signs of it, go in and get help.
But the problem is, there's not a lot of people there to help you.
It is a problem.
We're having more and more difficulty getting psychiatrists. We're having help with psychiatric PAs and psychologists and so on and so forth, but we're struggling with those numbers.
Well, and I think part of our strategy for that is to support our primary care physicians and say, I think what we also haven't done, because we've not really addressed it as a health system or as a nation and a health system, we need to kind of filter the illnesses at the primary care level when it's something and you catch it early and you can treat it with medication or counseling. That's probably a fairly large number, and I know you've treated many people over the course of your career for this. When it gets tougher, then those are the cases we need to move on up the ladder. But the other thing we're trying to do, and we need to continue to do, is integrate psychiatrists and counselors into the primary care clinic.
Yes, so that they're together. With the rates of suicide at epidemic levels in South Dakota, we are working to understand the environment that leads someone to decide that it's the best way out.
In total, suicides have increased between 1999 and 2016 by about 25% nationally. South Dakota has seen that during that same time period, a 44.5% increase as well. 2016 is the latest data available for all states, and we rank 13th highest for our suicide rate. In 2017, we had the highest number of suicides ever recorded in the state, with 193 suicide deaths. One of the things that we do know about that is that older Americans are at greater risk for depression, especially after loss of someone that they've spent their life with. So that creates a huge amount of stress in their life and can predispose them to suicide risk. So in South Dakota, we do have rates that are 2.3 times higher among our American Indian population than we do our white-raced individuals. And some of our higher rates among counties have been among some of the more rural locations, number one, but also counties that are primarily American Indian. I think a lot of it comes down to social connectedness, stigmatization for individuals in a specific area. There are the social support network is not as well developed in some of those areas. And I think the other thing to remember is that suicides are multifactorial. It's not just one thing that leads a person to commit suicide. There are a lot of other factors. Going to a healthcare facility or trying to go to a healthcare facility for a mental health condition is just harder in rural locations because they're either not available or not as readily available. And so when you're traveling long distances on a regular basis, it can be difficult, number one, but it may also identify a person as seeking out mental health care. So we do have Suicide Prevention Awareness Month, which is September every year. So we're doing a lot around raising awareness in communities, trying to decrease the risk of stigma with reaching out and getting mental health care, as well as the Be the One SD campaign, which is targeted at our youth in terms of helping them know how to approach an individual who may be at risk of suicide, who may be having problems. And we also have the sdsuicideprevention.org website that has a lot of good information. It has county level information on suicide attempts and suicides. It also has information for prevention toolkits for specific populations, including teachers, American Indian population, the elderly, and so on.
This is your program, and your questions are key to the direction of our discussion. We need your calls. This is a wonderful topic. We need your thoughts, your comments. Call in to 1-888-376-6225 or send us an email to ask@prairiedoc.org. One of the thoughts that I was told somewhere not too long ago was that one of the highest risk group is the elderly male who just lost his wife. And one of the things that we should do is that morticians, when they see a wife and there's an elderly male there, should notify the primary care doctor. We could do better in supporting those people at that time. High-risk person, what's your take on?
Well, I like what you just proposed, because what we need to do is kind of develop more proactive strategies instead of because I think particularly in this age group, and you're absolutely right, so this is a high risk group, and they have all the risk factors: living alone, often with a chronic illness or pain, bereavement, become depressed,
Become very
no
isolated.
Support system, right? So this should raise flags for us, but oddly, and this statistic always turns up, this is the high risk. We don't get a lot of these people coming in for treatment. We have a geriatric depression, a facility with a specific ward for that, and we certainly treat geriatric depression, but by numbers, these are not the people that come in for treatment. Or I don't think they ever express the suicidal ideation. I think they move from idea to plan to completion just very rapidly and without really seeking help. So it's a hard group of people to really reach out to protect and to save, because they don't come looking for treatment, would be my interpretation.
Yeah. My sense is that as hard as it is to predict someone who might be suicidal, because we've got a lot of reasons to think that we have, as lousy as we are at trying to find them, when we do, we really don't we can't even stop it sometimes. I mean, you know.
Yeah, so, and this is why I think it's so hard for families and practitioners. I mean, I don't know that there's there's a saying, you know, there's two types of psychiatrists, those that have had a patient commit suicide and those that will. I mean, it's an occupational hazard.
Yeah.
And believe me, it hurts. I mean, it hurts deeply and will make you kind of just reconsider everything you're doing. But that's nothing compared to what the families go through. And I think that's what's so hard is because try as you might, sometimes you're not successful. But that doesn't mean that we can't get better, and we do need to continue to learn. I think, here's what I would say, the one single most successful intervention we can make, and you're absolutely right, we're better at interventions than we are at predictions, but we still have to, our interventions still need improvement. Our prediction certainly does.
Yes.
But the single most important thing we could do would be remove firearms from anybody who's even had a thought. And actually, I would say I have nothing wrong with firearms. It's a family event for us to go hunting and things of that nature. But males commit suicide at a far, far higher rate than females, and primarily because their method of choice is firearms. And the other thing I think that is concerning about that is there's no second chance with that.
Right. It's a final
thing. So the greatest, it's called means restriction or means safety. This is a concept that's flowing across the country. It's accepted by everyone who looks at suicide prevention. Get firearms out of the house, and pills too, if you have anyone who's even had the thoughts, because you can't stop someone who's intent on it. But what we do know is that intent waxes and wanes. So that desire to end your life hits peaks and valleys, and you just have to protect against that moment when it peaks, and you say, I'm going to do it, and then hope they move on through and start to recover and reach a point where that isn't their intent.
Well, I mean, depression is a temporary condition. It goes away with time.
It can be treated. We're much better at treating depression, absolutely.
Right. There's been a lot of talk about treatment of depression, SSRIs, the danger of SSRIs in maybe enhancing suicide and so on and so forth. What's your take on antidepressant medications and suicide? And we've got some questions, and I so much appreciate it, but let's talk about antidepressants.
So I think what you're referring to, Rick, and this was brought out several years ago, that in young adults there was the potential with SSRIs to actually create suicidal ideation. There was never a link to
the idea of thinking about
it. The thoughts, but never the action. What was interesting in that, when that came out, practitioners reduced the number of antidepressants written, and we saw the suicide rate go up. So, again, cause and effect can be a tricky thing, and correlation is not always the same as fact. So I would say this, that I do know that it's been proven in research it can cause a thought. So there's a warning with all those types of antidepressants up to the age of 22. You have to say this may create suicidal ideation. But in someone who's depressed and having suicidal thoughts, I would
treat them.
I would treat them. And
there it is. And so would I. And I'm also if you looked at my whole practice throughout my whole life, I would say that at least 60% of it, even among all of the heart failure and all of the cancers and all of the diabetes and all of the chronic medical illnesses that I took care of, psychiatric illness is a big part of what I did.
Absolutely. It's prevalent out there, so let's quit pretending like we're not struggling with it, pretending like it doesn't exist. I want to make one more comment before we leave that last conversation. Yes. Medication is not the only treatment. There is good counseling, but cognitive behavioral therapy, I just am a believer in certain types of counseling intervention are more powerful than others. I think cognitive behavioral therapy is a wonderful approach.
And in one sentence, what is cognitive behavioral therapy?
It is working more with the thought patterns you have, how you approach problem solving, even somewhat your perception of self and perception of environment, and it works to change those, put them more in line with reality. But what I love about it is it empowers the individual to have you know, when you take a pill, that's a passive event. I'm waiting for this pill to make me better.
Right.
Cognitive behavioral therapy is to empower you, to give you tools to change how you feel today and tomorrow morning and tomorrow night. So I think it's
Very
critical
powerful.
that we don't say it's all about medications.
It
Counseling and therapy is exceptionally important too.
TMF,
Yeah. Transcranial magnetic stimulation.
which is MRI, the same as
Right,
MRI.
same kind of technology, so it's been around for years, very safe. Stimulates for depression, the prefrontal cortex. It takes a lot of time. Think of it more as rehabbing the way the brain works, the level of activity in the brain. And we know the brain is an interconnected organ, not only with the rest of our body, but certainly within itself. So by stimulating prefrontal cortex, activity throughout the brain is changing. So in those areas that we know are important to emotions, which are a little deeper in the brain, they're also stimulated. So I've had incredibly positive results with
Yeah.
TMS.
Is it covered by insurance?
It
Sometimes.
is more and more so.
Okay.
And Medicare now is covering it, which is a wonderful thing.
There are other treatments for depression. I've recently read, and we'll talk about it next week, but to talk about writing as a therapy for chronic back pain. If you write 15 minutes once a day of whatever it is that you want to talk about it.
It's fascinating.
And I've seen the back pain. The guy who is a
Well,
back surgeon is
yeah.
the biggest promoter of it, Hanscom.
How about bike riding and Parkinsonism? I mean, some of these neural connections and maybe ways to approach them. I mean, it just continues to prove that the brain is the last frontier, and we don't, as much as we know, we still have a lot to learn. And that's true about the entire field of behavioral health, right? We have a lot to learn. We're going to make incredible progress over the next several decades, but
We have more and more tools coming. My daughter was born in 1990, was diagnosed with depression and anxiety in her teens. She's now a young woman, and the depression and anxiety will occasionally flare. What are some tools that she can have in her toolkit to keep the anxiety and depression at bay as she enters into adulthood, deals with it chronically? Can you touch on the transition from teens to adulthood and the impact that would have? Isn't that a great question?
that's a great question, well worded, well written. I would say that it's not uncommon that we see people have their first episode of depression in their teens, early or late. Statistically, that probably means exactly what our viewer indicated, that she is going to have flare-ups throughout her life. So she's probably got a form of chronic depression that's going to be reoccurring. So in this case, what I would say is medications will be a benefit. But again, I like the idea, empower the patient. So I'm a firm believer, as I just said, in cognitive behavioral therapy. It gives her some
Tools.
self-talk, some perspectives. But I also think pay attention to little aspects because a 5 or 10% improvement in mood or stability adds up. So there's a cumulative effect to things like proper sleep. Sleep is critical in mood disorders, and we underestimate it. And it's not just enough hours of sleep, but it's go to bed at the same time, wake up at the same time. Do that on the weekends, do that on the weekday. Exercise, diet. So sure, this is a mantra we repeat about every chronic illness, but we don't always apply it as rigorously to mental illness as we do to other illnesses, but it's just as applicable, and there's more and more data about benefits of exercise. And the sleep cycle is critical, but even things like exposure to sunlight, if you notice that it's spring and fall. So you can use artificial, bright light therapy. It has to be a full spectrum, it has to be at a certain distance. There are other effective ways than just relying on medication.
I like the idea of going out for a walk every day, right through the winter, unless it's really slippery, but right through the winter, getting outside, or if you can, when it's safe, but 1 mile a day, just 1 mile a day, just 12 blocks a day. Walk away from your house 6 blocks, come back. It doubles the effect of the antidepressant. I've read that. Do you agree?
I thoroughly believe that. Well, I think inherent in what you just described, creating more structure in your life. One of the things that I always find interesting is patients come into our facility to be treated for depression. We put them on a schedule. We have a time of day you go to bed, you get up, you eat your meals, you go to. It's a very structured lifestyle. People often feel better within a few days. Obviously,
just to have the structure.
Right. I think the structure is a component of that they sometimes undervalue. I mean, the groups and the support and the therapy you get, clearly we think those are key players.
Wow.
But I think the structure is an unrecognized benefit.
Maybe that's why our society is all this increase in suicide, because the structure is all over the place, I think, right now. Where do people get fentanyl on the street, and how do the dealers get the drugs? It's Joe down at the corner of 4th and, I'm just joking, that was a joke. That wasn't very funny. It's out there.
It is. So, let me describe what fentanyl is. Fentanyl is a synthetic analog of a narcotic. So it can be made in a lab. So unfortunately, it's relatively easy to create. And so this isn't like our meth crisis where it's being made in bathtubs. But what it is, it's made in other countries and other labs. I understand that a lot of it is imported from China, India, countries like that. I can't pretend to begin to describe the mechanics of the dark web, but apparently you can order these things over the internet. They can be shipped over. But where it usually occurs is it's not directly to the patient, but they're buying heroin or they're buying street
Fentanyls.
Yeah, street narcotic, and fentanyl gets mixed in. And if you understand that fentanyl, as I said, can be 100 times more powerful than the prescription narcotic you were given, and an overdose means your respiratory drive shuts down. So if you see someone who's poisoned themselves with this powerful narcotic, it's going to look like somebody with terrible sleep apnea. They're going to start snoring, breathing, but the pauses between those breaths get longer and longer, and then they just stop.
Yeah.
It's just like someone with sleep apnea, they just go into a deep sleep and stop breathing.
Yeah. I'll tell you what, you have a bad feeling for the word fentanyl. I have a good feeling because it's like the number one patch medicine that I prescribe as a hospice director for my patients who are dying.
Yeah, and it's a good distinction because it isn't the prescription fentanyl that's getting out on the street. This is coming from labs. More concerning is car fentanyl. So take 100 times more powerful and now crank it up to as much as 10,000 times more powerful. Wow. Police, when they see these outbreaks, they have to wear personal protective equipment because if it even gets on the surface of their skin, they may go down. Yeah, seriously. So it's frightening how powerful these drugs are. But they're not diversion of prescriptions for the most part. They're coming from outside labs.
That's what the bad fentanyl.
Right.
Tragedy befell a Yankton family when their son, an SDSU graduate, in the process of earning his law degree, committed suicide. They have suggestions for family, friends, and the healthcare system drawn from their personal experience.
The summer after he finished his first year, we started noticing some things, and he started expressing some concerns about his happiness. We had many, many family conversations, and we had spoken to him about getting some medical help, which he did. And 30 days later, we lost him. It will be 3 years this Friday, September 28th.
I wish we could say, watch for this specific action because it's going to lead to that. I wish we could say that, but we can't. I wish we could say that this medication is to watch for, but we can't. I think the one thing we really do say now is that we feel very strongly that the medical profession right now, I believe, has some major gaps in it. And one of them is that most of your mental health type of medication, your anti-anxiety and your anxiety medication, things are prescribed by a physical health care doctor. And nowhere along that whole scene, while Sam was underneath that healthcare doctor purview, did he ever see a behavioral health care doctor. And I want to, before I am gone and finished with this project, I want to see those offices across the hall from each other. If you're going to get the medication, then we go over and see the mental health care for also. It's just that we don't see it. If we don't see it, then does it exist? And that's a big problem for us.
It's something that needs to be talked about and not afraid to be talked about in a casual conversation. A month after Sam died, our niece went to her parents, my husband's brother and his wife, and admitted that she was having deep, dark thoughts. And we have seen her get the help now in these last 3 years that she deserves to have because of the communication, because it was in her backyard. So we know that the conversation needs to keep going. with these young people with any age, um, however it can be done.
Death isn't the real what they want. That's not what they want. And I know it's hard to go back and say, oh, how do you know that? But all the research, all the counselors, many of it is it's just a way to escape the pain that they're feeling, the angst or the anxiety or whatever that constant pain is. Many of them don't sleep well at night, go through those processes. The best way we can approach them and find them is to continue to talk.
Well, our heartfelt thank you to the Garrity's for the courage to bring that message to us. You know, I think about the severe impact that suicide has to the family around. I mean, it is one of those deals. I've never seen so much suffering as I've seen following a suicide, because there's guilt or there is, talk about that a little bit. Matt.
Yeah, well, I think you just touched on it. Every family, you know, and we've all felt this. I would do anything for them if I would have known, or if they'd told me, or if they'd have come to me. And you know, you have all those thoughts. They had everything to live for. This was a temporary problem. Things would have got better. It just doesn't make any sense, and oftentimes it doesn't even mesh up with the person you knew. I think one of the things, again, and I think we underestimate how depression can change your perception and your way of thinking. Because I know, and I hear this repeatedly, I can't believe he did that. That's just not the person he was. Well, that illness not only changes the way you sleep and the way you eat and the energy you have, but it actually changes your perception. And the most profound example of this I can give you is when we see depression progress far enough, we actually see people hallucinate or see things, hear things. Yeah, so they've lost touch with reality. So if depression can take you to that extreme of wrong perception, it certainly can compound your sense of shame and guilt and worthlessness and hopelessness. Yeah. So we look at them and say it doesn't make sense, and it doesn't, because we still are in a rational mind. So that's part of it. But that ripple effect, the pain and the harm and guilt, when do we ever have something happen to someone we love where we don't feel some twinge of guilt, right, even if there was nothing else we could do? Right. So,
well, and anger.
Anger, absolutely.
A friend of mine committed suicide, and I was angry at him because what he did with it, and I mean it was and then I feel guilty being angry.
Yeah. Well, you're angry at him. You're angry at the person you thought should have helped him and didn't, or there's. Angry at yourself because why didn't I know?
Why couldn't I have done something?
So, and we all, it's like any form of grief. We all deal with it in different ways, and we all move through that process at a different pace. Yeah. But I loved what the Garrity's said, and part of that I take home is we do need to learn to talk about it. We need to be able to share this and not feel shame or run away from these. They're difficult topics, but we can't run away from them.
Right. So important. Well, we've got some questions. We need to kind of roll through them.
Great.
Can you touch a little on some events that lead to suicide? Loss of jobs, decrease in self-esteem, loss of money?
Yeah. So some of the risk factors are what you just described, and it's interesting because we can describe risk factors, and that will give us a broad picture maybe of who might be at risk, but it doesn't really help us to narrow down or hone in on who is at risk. So I want to make it clear, people can have multiple risk factors, bad events happen, and never have a suicidal thought. Others will have what seems to be a relatively minor hurdle put in front of them, and it will result in this suicidal ideation. So there is, again, I go back to the concept of medical illness, chemical changes, highly impactful in the situation. But we do see some high-risk periods are, during bereavement. It's, having had a family member or loved one commit suicide puts you at a higher risk. interestingly, post-incarceration, so people coming out of jail or prison are at higher risk.
Wow. Is that part of the lack of the regular rhythm of life that you were talking about earlier?
Yeah, and I think what it points to is anytime we have these traumatic transitions, whether it's being, I lost my loved one and I have to learn to live without them, I'm used to this prison environment, I can't, all of these are traumatic transitions. I think those are a risk in themselves.
Bad grades. They say that that principals who bring the kid to the school and say, now you got to know that your grades are so bad, and here's your report card. You take it home and talk to your parents about it. And then of course you commit suicide. I mean, it's these younger people do things without thinking. I mean, it was just it's suddenly I'm going to do it, and this is the answer, and they do it.
Yeah, and two comments I'd like to make about that. So one of the things is never consider someone saying they have suicidal thoughts or they think they should just be dead. Never disregard that. Always follow up on that and try to do it in a non-judgmental way, just hear them out empathically, because your first response is, that's silly, that's crazy, you got everything to live for. You don't really think that.
You don't think that.
Right. That's not going to change the outcome. The other thing that's important here is asking the question doesn't create the thought or elevate the risk.
So if I said, Matt, have you been thinking about suicide? That did not raise your
chance. I didn't magically go from, gee, I've never thought about it. Now, oh, wait. Because I think people worry about that. That's clearly been studied. That's clearly not the case. In fact, the opposite. By not asking, by not taking it seriously, inquiring, you are going to lose an opportunity to potentially intervene.
Right. Are you familiar with the dexamethasone depression test for the diagnosis of depression?
Right. Yeah. So it does have some degree of validity.
That's a test that we use for people who might have an adrenaline tumor.
Right. So it's your cortisol response,
right.
and so it will it will indicate that your hormonal axis is impaired. I think it goes back to it's another validating component of the argument that this is a medical disease, hormones, other things, neurochemicals are impacted. I think the limitation is that it's not necessarily any more. I think it helps people to validate their illness when they're not clear that they're depressed. But we primarily diagnose depression through meeting a symptom criteria list. And that has shown to be as valid as the dexamethasone suppression test. Yeah. So in a nutshell, it would make you go through a laboratory process that you don't really need to make the diagnosis.
The caller has had 3 people close to them commit suicide. Are some people prone to self-destruct, and is suicide inevitable?
Well, I don't think it's inevitable. I'd like to believe that we have helped people that otherwise would have committed suicide and haven't, but not every intervention is effective, and certainly can't say that we've helped 100%. I think what's interesting here, and this is a tragic story, probably all too common in some areas, but it's what we just talked about. If you have known someone or been related to someone to commit suicide, it elevates your risk. It does. It clearly does elevate your thinking about suicide. And then as we go through the grief process, and we're at a higher risk for depression. Depression is a higher risk for suicide. It creates a whole cycle of potential problems there.
When you have somebody who wants to commit suicide, what they're saying is they're going to do it no matter what you do. My answer is get the guns out of the house.
Right.
Get the guns out. Talk therapy, get to professional help, and don't give up on it.
Well, and here's an interesting point of view. So I have worked with and talked to a few people who attempted even shotgun to the chin and survived. Every one of those people has told me, even though mangled face, I'm so glad I'm alive. So they were at the point of death. They were sure they were doing the right thing at the time, but after they survived, they were happy to have survived. Those are people that came extremely close to death, and there are actually people going around the country now talking about this, survivors. Conversely, though, I've had people that have attempted suicide, maybe didn't get as close, or maybe said, why did you stop me? So I have to take heart in the fact, though, that the people that I believe made the most serious attempt and came the closest almost inevitably will tell me,
They're glad they did.
I'm glad I'm alive.
Yeah.
So I don't think it's an inevitable end. And those people went on to improve their lives and live.
Help others.
Right.
My brother committed suicide. He was a happy man with a happy family and a job. What are the possible reasons? Why?
Yeah, it's very hard and hard to know. And I can feel your pain through that question. You know, sometimes things are going so well when we fear we're going to lose something that's so perfect and wonderful. And he may have, I've known people that have serious depression also that from outward appearances you'd have never known. So it's really hard. And this is what's so hard about depression. You're doing exactly, or suicide, it's exactly what we talked about. You're left with the questions. You're left with that desire to understand, and you would have done anything to help, but there was no knowledge.
Right. And I think, you know, when it does happen, I think because it happens doesn't mean that it's your fault, and you've got to let go of the guilt, get on with your life, and relieve yourself of that the pain that's going on. So that's the big part that I think that's the hardest for families.
Oh, I absolutely agree, but I agree with exactly what you said. I mean, this is not an event that someone's to blame or has a cause. Even the person, you know, who committed the act, I truly believe, you know, they were not in their healthy mind. This was a
temporary illness.
Right.
Temporary.
And what's concerning is sometimes you see this in young people where emotions are really, you go through highs and lows, and as we age, we kind of forget how intense those swings can be, and you know how everything seems so dramatic. It's so, oh, this is going to ruin my life, or this is. So I think, especially in that impulsive, when you see a child or a young adult who's going through a lot of mood swings, has voiced any kind of suicidal thought, definitely inquire, but get the guns out, get the, and the drugs, you know, the prescriptions too, but firearms, single most important thing we can do.
We've got 3 questions, 2 minutes. I have been a widow for 7 months. How long should I expect depression to last after the loss of a spouse? What is the reason to take antidepressants? Or is this a reason?
Yeah, so
7 months is
it's getting on the borderline of. I mean, let me make it clear. So bereavement lasts for years. I'd have to probably know a little more. But if you're seeing it impact your energy and your sleep and your appetite and other factors, at this point, I would actually talk to your primary care physician and just mention that. I don't know that you need to be on antidepressants. I certainly wouldn't prescribe those over the television, but I think it's time to have a discussion. And there are support groups for grief, and there's therapy for grief. It may not even require medication.
I start the antidepressants at 6 months if they're still hanging.
I think that's reasonable.
Yeah. Is it possible the overdoses of opioids is big part of the suicide crisis? Are the opioid numbers added to the suicide statistics?
It's a great question. They are not. They're viewed as overdose poisoning.
But some of them are, aren't they?
Yeah, and there's certainly a gray area there. I have no doubt that there is, which is true of every substance use. About a third of suicides are related to have an alcohol use component. So substances and suicide.
Big risk for suicide.
Yeah, and they're very intertwined.
Yes or no? Is there a link between concussions and depression?
I believe yes in some cases.
Yes.
And the jury may still be out on that, so I can't be conclusive.
Okay. And now for the winner of tonight's Prairie Doc quiz question. Pick the best answer according to the CDC in the year 2016, and in the U.S. there were 1, twice as many homicides as suicide; 2, the same number of homicides as suicide; 3, twice as many suicides as homicide. Matt?
Twice as many suicides as homicides.
Twice as many suicides as homicides. Think of that. Of 100 people involved, 66 of them are suicides. It was Dale Clement of Miller who answered the question correctly. Thank you, Dale, for participating, and a book will be in the mail to you soon. We'll be right back after this.
I always saw her in the hallway, but she never talked much. I just figured she was shy. One day at lunch, I was sitting at my regular table and I saw her all by herself. I was pretty popular. My older sister was always liked by the teachers, so everyone knew my name. That's why it was so weird when this girl, who I never talked to before, just walked up to me out of nowhere and asked if I could talk to her. So we talked. Actually, I talked. And she just sat and listened. And for the first time in a long time, I felt like someone actually saw me for me. Later, she told me that she had noticed that something had seemed off with me that day, even from an outsider's perspective. And she decided she would be the one to reach out, just in case. She didn't know that I was seriously planning on taking my life that night. But because she decided to be the one to care, to ask that one question, "Can I talk to you for a minute?" That's why I'm still here.
Depression doesn't discriminate. If you think someone you know might be in crisis, reach out. Visit BeTheOneSD.com for signs of crisis or depression. Then be the one to show you care.
South Dakota has the 14th highest suicide rate in the United States. And during this last year, suicide as a cause of death has grown faster here in South Dakota than most places. 2 South Dakota counties rank in the top 1% in the nation. I've heard that in general, the highest risk individual for suicide is the widower, the elderly male who recently lost his wife. But the South Dakota Public Health Department tells us that suicide rates are higher here in younger people than in most other states. For example, men aged 19 to 21 years old are at the highest suicide risk. In addition, American Indians are at 1.8 times higher risk than other South Dakotans. Risk factors for suicide include a family history of suicide, a history of abuse, be it the abused or the abuser, previous suicide attempts, or a history of mental disorders, particularly depression, and especially if the individual has difficulty accessing mental health treatment when needed. A prior experience of alcohol and substance abuse, feelings of hopelessness and loneliness, especially with isolation, recent loss, whether it be the death of a family member, a friend that moves, a divorce, or large financial loss. Any new and significant physical illness, and access to lethal methods. Also, there is a higher risk for anyone during local epidemics of suicide, especially where cultural beliefs suggest that suicide is noble. All this multiplies when the person is reluctant to seek help because of the stigma attached to mental health disorders. The challenging concern is that suicide remains extremely hard to predict. Even when we've identified who is at risk, suicide can be difficult to prevent. We know that talking about it is probably our most important means to help someone who's planning suicide. Although we should all try to guide these people at risk to talk about their feelings with a professional, the most important preventer of suicide is in many cases not the doctor or the care provider, but the kindly neighbor who can give that person an ear, offer true friendship, and call for help when red flags are flying. You may never know it, but you might save a life by listening and just being a friend. Governor Dugard and the Public Health Department wanted us to talk about suicide, and this is Suicide Month. A big thank you to Matt for volunteering again to come to our studio. I'm going to owe you something for all of this, Matt. To Yeager Hall on the campus of South Dakota State University. Matt has a way of making whatever program we invite him to join so much better. October is Pancreatic Cancer Awareness Month, and the annual Light the Capitol Purple event is October 28th at 3 p.m. on the Capitol Rotunda and Pier. Don't miss it. This year's featured speaker is Dr. Gary Timmerman. And we're getting into the annual flu season. It's really not too early to get your flu shot. It's important, not just for you, but to help protect those around you. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
He didn't always know he was doing this, but Dr. Holm spent his entire professional life doing research for this book. Lori Walsh and the Prairie Doc will visit about the journey, life's final season, next time on Call with the Prairie Doc.